She's a associate clinical professor at Yale, and she is an age management medicine practitioner in New York City, and has been doing that for, what, 4 or 5 years?
4 years.
4 years. And she founded the Women's Health at Yale, and she's a leader in women's health for the last 12 years, over 12 years. I present to you Dr. Florence Comite.
Thanks, Jack. Okay, well, apparently I've had 15 minutes cut off my talk, right, Jeff? I'll do my best. What I'm going to try to do here today is, even though I'm a reproductive endocrinologist and I've had unusual and very fortunate training in that I trained in every field of endocrine at the National Institutes of Health that focused on hypothalamic, pituitary, gonadal, and adrenal. So I was lucky enough to be at the frontier when human growth hormone, HCG, testosterone, the advent of all of these hormones, both peptide and steroid hormones, were getting attention, the knowledge that the system is a pulsatile system and not quite stationary, which won a Nobel Prize, all happened in that vicinity of time. And as a result, I was not trained only as a classical adult endocrinologist, which focuses on diabetes, thyroid, and bone, but rather looking at growth, development, reproduction, and I've done research largely in the first third of my career in pediatric endocrine, the second in gynecology and endometriosis and fibroid and infertility, and in the last third, which I like to stick with because it's a lot of fun, is andrology, which basically doesn't exist as a specialty yet, but I think it will in the future. But I'm really not here today to talk to you about the endocrinology aspect of it so much as what we need to do to surround it. I think we need to position ourselves, because we're at the frontier of a major upheavals in healthcare over the next decade. It's happening around us. And we, as age management medicine doctors, and those of you who may aspire to learn the field or go out in new directions, are particularly poised to take over healthcare in a way that the changes will, I think, allow us to thrive and prosper and help our patients and remember what it was like to be a doctor, to guide, advise, and be trusted. The burden of aging over the next 10 or 20 years in cost is going to be astronomical. And today's costs will simply pale. And staying in the best of health is probably the only choice for our patients. They may not be candidates for things like stem cells or a heart transplant unless they don't have disease. And as we know, disorders of aging are clearly linked to disease, because as we age, our systems can't maintain metabolism, can't maintain health. We begin breaking down, our DNA shortens, and that's what aging is all about. And I know we've heard and learned much about hormones over the last 2 days, but I want to let you in on the secret. It's really who we all are. It's not just about hormones, but it's about you, your compassion, your training to be a doctor, to care for your patients that drove you to want to do the best you can do, and we've been unable to do so. And that's not a political statement. I just want to make that clear to everybody. So you are really ready to own this kind of brave new world of advising your patients and maybe partnering your patients. My talk today will break down the facts of this inherent knowledge we all own due to the rigorous training and experience as doctors. And I will be going over samples of cases to point that out in my practice, to touch on how this can be actually brought to fruition in whatever position you're in today. By the end of my talk, I think you'll understand why the value proposition to become the kind of doctors that we all yearn to be, probably when we were first applying to medical school, is available to us. Of course, there's a new infrastructure that we need to implement that is not always easy to accomplish. It means working in sync with your patients, not being necessarily God or goddess, but rather guide. It means maybe creating an internal support system in your own office that might include different kind of specialists like exercise physiologists or nutrition experts, clinical and administrative support, and probably, it's my belief that an external network, a system that you need in your own personal settings. And you'll figure that all out, because what may work in Manhattan on the Upper East Side is not going to work in Boca Raton or in Las Vegas or in California necessarily. Okay. So the overview, as I kind of generally spoke about it, is conceptual, trends in health, today's reality, age management, the science and the approach, the case studies, and final thoughts. If I don't have time to get through all the case studies, you should all know that not only is there a lecture in slides available, I guess, in your CD, but along with it, I actually created a handout that goes into deeper detail about all the patients, because I was hoping we'd have time to interact about the cases, but being on a CD, it's a little hard to interact with the CD. Okay, I'm going to dedicate this lecture to my father, whose birthday, his 97th birthday, would have been today. This is my dad at 92 in the gym. And I had the fortunate opportunity, which I yearned for and made happen because my mother decided she didn't need me to help her clean. She sent me to the gym with my father, and I thought I'd be seeing him trudging on the treadmill the way older folks seem to do. And no, I was trudging on the treadmill, and he was out there doing weights and resistance, and he burned me out, and then he went for a swim. And so as I drove him home that day, and this was September '02, I remember saying to him, Dad, how do you feel now? He was 40 years older than me at the time. And he said to me, I feel 1,000% better than I felt at your age. Now I have the time to invest in my health, my well-being, and really that statement really meant so much to me, because for the past 20 or 30 years, he's been my inspiration doing this kind of work and looking towards how do we sustain health and create a prevention-centric model of healthcare instead of the disease-centric model that we're also used to, putting out fires that we have no time to talk to our patients. So the trends in current health and consumer behavior show that there are powerful shifts in demographics and preferences and attitudes about what it means to live long, healthy lives. These trends will change the way people live, vacation, shop, work, and take care of themselves. Trend 1, it's not about getting old. It's about staying healthy enough to enjoy all that life has to offer. I don't know about any of you, but I have many 70-year-olds who climb mountains that I couldn't climb, and they're in terrific shape. And just a few months ago, there was an article in the New York Times showing marathoners who reach the age of 95 to 99 thrilled that they're going to be the youngest in their group because now they might place. So it's happening around us. Our patients want to not only live till 100, but ski at 120 if they can. The very nature of health and wellness itself is changing. Health is the state of not being sick, but wellness, which we all want desperately, is the state of continuing health. This unfortunate trend that the physician is no longer in charge, nor the font of all wisdom, nor effectively integrated with other health and wellness providers, is really what is pivotal to where we need to make change. We need to work not alone in silos and in fragmented environments where if you're this specialist, you don't necessarily interact with that specialist, because there's too much translational work going on, and there's too much need for knowledge that has to be exchanged with our patients and other physicians to let that be conveyed by our patient who may not have the wherewithal, the knowledge to really understand what the important points are. So that it's another role that I'll be speaking about as well. Trend 4, choosing trainers. I chose my trainer, and my trainer said, go for it. And trainers are critical, but one of the reasons I ended up starting Women's Health is because I had lots of my patients were in great health, just like the marathoners in Detroit, 3 of them who dropped dead, or in New York. But exercise and nutrition, while critically important and still not taught in medical school, is not enough. We need to know what those genetic triggers are, those markers, and what in the environment and what in our own lifestyle can bring them out, and how do we suppress them, and how do we get the best of what we can be, kind of leveraging the assets of our health while we minimize the liabilities for our patients. So there are startling advances in health services that transform the meaning of age itself. I was amazed and delighted with the stem cell conference that I was lucky enough to pop in and out of, the health and stem cell one, and I thought it was a miracle. I saw Parkinson's patients by Dr. Brody get up and walk, and expressions on their face, and some of them were even running. And, I wrote his name down, and I know I have patients who are going to do everything they can to get there and get that kind of input, because as we begin to figure out functionally what's going on, we can make differences. More important, these fundamental systems are allowing someone who's 89 looking like she may be 47. And these changes, as I learned subsequent to the stem cell conference from a plastic surgeon who came up to me afterwards, telling me that the one type of cell in our body that we all love to get rid of, fat, is actually the best source of stem cells. It's pluripotential, and it can go anywhere in the body and transform into anything. And he said in the next 5 or 10 years, instead of culling cells out of blood and stem cells and growing them, which is very labor intensive, all we need to do is grow more fat, which I don't seem to have a problem with, and then by sucking that fat out, that fat could be re-injected as stem cells. I thought that was just amazing, and I can't wait for that as a shortcut to some of the things we have to do today. So what's today's reality? I'm going to speak about the summary of current situation. Patients are overwhelmed with information. It's difficult to sort out the facts. They know too much but not enough. In fact, 20 years ago, I remember being first called by people in the media because of research I had done in women's health, and these women were turning 40, and they were being told that their symptoms were ridiculous. We didn't even really know that the perimenopause existed at that point. It was really not a common terminology. Just like today's people still wonder, do males really age? I mean, do their hormones really drop? That can't be the case. And there are lots of people out there who still think that's true. And at that point in time, in order to get medical facts, you had to go to the library. You had to have resources. You had to have a press card or be a doctor or a student. Nowadays, we're bombarded by facts, but everything on the internet glows. We don't know what's good, what's bad. It doesn't gracefully grow yellow with age like books in the library. So it actually has been shown in studies that it produces more anxiety to have too much information. So here we are, pivotal at a place where we can interpret. We have the experience and not just the knowledge, but the wisdom to pull in expertise from our colleagues, from what we read from the internet. So our sources are readily available with a click of a button. But interpreting it is what we need to be positioned to do in terms of guiding our patients into the future. Patients will try many things to find the right fit, and they're very confused. So you need to hear about their old and new symptoms and look at a variety of attempted and current treatments and therapies. And you need to sort out for yourself, because medicine as we know it is nothing but black and white. It's gray. It's not black and white. It's totally gray. It's difficult to sort out. The evidence to me is like the emperor who doesn't wear any clothes. It gives you some information. It's a great starting point. It's what you need to do to start with your due diligence when you try to figure out your own answers. But then you have to look at the fit. You have to take an individual and say, if she doesn't quite fit within this absolute evidence range, she's not one of the types of subjects, what's different about her? Because as we all know, the normal curve ranges from -3 standard deviations to +3 standard deviations, and most studies select the bump at the top, which is 1 plus to 1 minus standard deviations. The person at -3 standard deviations is 180 degrees different than the one at plus. So how do we reconcile the facts? So evidence works for me. I love evidence. I've published. I'm known for publishing in earlier parts of my career in the New England Journal, Annals, archives, but evidence is just not enough, and within the next 10 years, we'll be moving away from evidence-modeled medicine as we begin to learn the genome and what really makes us unique. I like quoting from Jane Brody, who's a very informed consumer, because the confusion of what's out there is so readily apparent. And she had this one piece 3 years ago now, which talked about the news around the health, women's health, along with other studies that were out there. And she spoke about, forget about those hard-to-swallow tablets of calcium and vitamin D for osteoporosis or glucosamine and chondroitin to stem the pain and progress of arthritis, and a low-fat diet to protect her from heart disease and cancer. Why not eat eggs Benedict and burgers and shakes and ribs and fries and give up her daily exercise and recoup the hours spent in the gym and pool? But wait, says her better judgment. As convincing as the new studies appear to be on the surface, I see ample evidence to continue with my present regimen, even if it may not afford the protections that the WHI or the NIH were examining. Think about the havoc we face every day. In fact, it's one of the reasons I think this field, at least initially as it's presented, appeals to men, because women and their doctors are totally confused by one piece of evidence that emanated from the WHI studies that's completely changed the fabric of the way we practice with our women patients. So she refreshed our memory about a low-fat diet with no overall benefit to the hearts of postmenopausal women, nor did it protect them against breast cancer. Another arm of the study showed that there was no protection against fractures or colon cancer from calcium and vitamin D, which actually increased the women's risk of kidney stones. And if those counterintuitive findings were not hard enough to swallow, hopes for quelling arthritic pain with OTC supplements was dashed also by another study. And then she starts talking about her own recognition in her own dog, who, as she says, giving him 3 capsules of glucosamine 1,500 milligrams and chondroitin 1,200 milligrams, transferred him from an 11-year-old spaniel dog from an arthritic wreck into a companion with puppy-like agility, giving him nearly 6 more active years. And the dog had no idea what the capsules were, so it wasn't like it was a truly blinded study, and nor that he was even getting them because she hid them in the meatballs. So as far as she knows, there possibly wasn't a placebo effect there. And although her knees were arthritic, she was able to go back to playing singles tennis and walking 3 miles a day, and her hands improved. Colon cancer was less of a risk for her because she had a colonoscopy, but calcium lowers the risk of high blood pressure, and there's growing evidence that vitamin D, as we all know now, is not a vitamin, it's a hormone, and it protects against cancers and autoimmune disease. So I won't say anything about this study except to say this is one of the fundamental reasons bioidentical hormones, usually information seems to be emanating from Suzanne Summers instead of doctors. And it's a wonderful thing in some ways, as long as it's not misrepresentation, because I think the public listens to some of that and they begin to believe that you can tear down the walls and understand it. Okay, so we are approached by our patients who are dazed and confused. They don't know what to do about all this information. They're not Jane Brody. They're not systematic. They're afraid to do things that they do because they may be in conflict. No one knows how to put it all together, and every day I learn something that I am doing will do me harm. So as Dr. Hess said yesterday, I'm afraid to take the hormones, but I'm afraid to stop, of one of his women patients. Another piece in the literature that many of us read and all our patients see, this was a great study, and before the advent of stem cells, I would tell my Japanese-American patients, 8,000 of whom were studied here, that if they drink 4 to 5 cups of coffee a day, they don't get Parkinson's. The relationships are clearly unknown to us. So science is built up with facts as a house with stones, but I think what we all need to remember is that evidence and facts are no more science interpretation than a heap of stones may be a house. I particularly like this one, the Random Medical News, saying that coffee can cause depression in twins, according to a recent study. I happen to be an identical twin. She's the smarter twin. She's a dermatologist, as my mother reminds me all the time, but telling me I need to visit her, which I keep telling her my health is better on the inside, even if she looks better on the outside. But this information, again, just adds to the confusion and the anxiety that our patients feel. We are perfectly poised to advise and guide patients to make sure that we don't relay black and white feelings or maybe our own biases, but rather interpret it through the eyes of the patient, who they are, their lifestyle, their approach to life, their desire or lack of thereof of taking lots of pills. And doing that, you'll have a shot at really positioning yourself to grow, as hormones, exercise, and nutrition are not going to be enough. Over the next 10 years, many of us will be doing that. What do we do to get beyond that? Where do we go? Why can't we absorb it and then select what will create not just great medicine, but let that great medicine drive a great business, because we're in the perfect position to do so. Today's current medical reality is putting out fires. We're too busy as physicians. I think the data shows a regular family doc or internist or the generalist spends 8 minutes a year talking to a patient. They don't have time to ask you about the latest events in your family, which might impact if your mother just broke her hip or your father was diagnosed with diabetes and you're 40 or 50 years old. That's pretty important because you can probably see signs of it emerging internally, even if it's not evident externally. So if you have an MI, the patient will exercise and you'll tell them about it. They get diabetes, they'll limit carbs and you know what to do about it. Find cancer and maybe, not all, but most patients will stop smoking. But our goal is to identify the emergence of disease before we see it so that we can reverse it and perhaps never allow it to emerge. As Dr. Alan Mintz would say, dying healthy, with all your pieces intact, fading away. So what does this age management medicine model of medicine allow us to do? I'm going to speak about the model, the science a little bit behind the medicine, time permitting, the approach to advising and guiding, and the proactive management of the client. And now, before I hear any gasps from the audience, I would never use that word client in an academic environment because I'd probably have my head handed to me. I don't like the word customer because I don't think that way. But the reason I use the word client is because I don't feel that patient is the right word for our patients because they're not sick. And to me, being a patient in this medical environment connotates illness. So I tend to go back and forth between clients, patient-client, client-patients. I never quite get it exactly right, but it positions that human being in front of me as a human being who is there to get my help, to talk to me, to figure out, to be curious about their needs and desires and hopes, and then ultimately to give them the wherewithal to get on with it so that as they age, they actually get healthier. So sustaining your edge in this economy and in this world of medicine today, it starts with identifying your patient's assets and liabilities. You look at establishing a risk profile, guiding and partnering them, consulting and referring, coordinating and consolidating. You can create a virtual network that surrounds each patient and that goes out in circles as far as that patient's particular needs. You have a patient that has a strong family history of prostate cancer and heart disease. Well, you'll want to make sure before it's necessary, and maybe it'll never be necessary, to perhaps have a great cardiologist that's going to work well with that patient of yours, or a urologist, or look at the picture and see what is it that's going to be essential so your patient hopefully will never end up in the hospital, but get opinions at the leading edge of what's new in medicine today, and you help translate that. You will sustain your patient's health proactively and deepen the relationship, which leads to a very viable and healthy business because their trust in you will grow. You will become the 21st century version of that old-fashioned family doc who is still buried in all of us today because I believe all of us wanted to go to medical school to make a difference. And it's time to sort of dust that part off and figure out how we do that once again. So I came up with this little slide that positions a age management medicine doctor, but it's not necessarily the name. It's the name of whatever field you find yourself in. To position yourself as a guide, as the person who's the essential element in conferring with other MDs, in talking to family members, in coming up with translations of what goes on in today's healthcare environment that's challenging for even us as doctors to understand. And I know because I have some of the best and brightest doctors who are my patients. I have about 40% of my patients are male doctors. And they come from all stripes and colors and all over the country and outside the country. And none of us know answers. We're all on a search for it. So think of the loss our patients have when they are facing some crisis and how much better it is for them, for you to guide them to prevent those crises, number one. But if something happens, there's a spontaneous accident or something occurs in the family or there's an urgent issue, and you gain their trust and work with them, they will stick with you forever. They will grow with you. And you know you will get other patients coming from them as well. This is one such patient I'll touch on, one of the 13 cases I may have time to get through. JB is an 82-year-old patient, and he's been on Wellbutrin and Lexapro for 2.5 years, and recently showing more signs of anxiety after loss of his job on Wall Street, where he's an essential element, but with the economy cut back, he couldn't stay with it. And he had decreased cognition. There was a very strong family history of dementia. His father died in Creedmoor, which is a mental state institution in New York, and his 2 sisters also died of dementia. AB, and they're both my patients because AB referred his father to me after losing 50 pounds at the age of 60 and developing a six-pack, and diabetes went away and his cholesterol, he stopped taking his statins. He had concerns about his father, but he was also caring and worried about the implications for himself. So we ended up referring his father to a neurological associate group. And because of lack of time, I won't go into the detail, but a lot of this in the letters without the names are all on your CDs. And we talked about the possible reasons, but I spoke to the doctor before his father went there. I positioned it. I was able to tell him as if I was a member in their family who was a physician. Let me tell you what's going on with him. Let me make sure you have the facts. Let me send you the data so you're not starting from scratch. So I was able to show them his thyroid and other signs of function and tell him exactly what was going on. So instead of leaving the details up to the patient or the family who are struggling because they're in a crisis and they don't think clearly and they may not even express it correctly, so it's hard for that doctor, it makes it less efficient for the doctor, and the information that comes out on the other side may not be as good information. It may not be as helpful. So here you are playing a role that can make a huge difference in decision making. So there was a treatment plan, there was discussion of it that went back and forth. I get to know the community in doing that because I was new to New York as I transferred there 4 years ago, and it was an opportunity to work and network and then have doctors in my sphere who also would start referring to me, and I would have trust in them in terms of caring for my patients. And there were a number of things, as you can see mentioned here, that went back and forth. Did we measure this stuff? What about starting him on aspirin? Was he on it? Do we initiate Seroquel? Do we stop his Celexa? And then the workup, which did reveal some early signs of senile dementia and the ultimate treatment. So we are in a place where organic growth and extending who we are across specialists and family is possible, because we may, as the age management medicine doctors who either are or want to be, or the others in the room who simply want to add this as a facet of their current practice, we are going to be able to talk proficiently about optimizing hormones and what that does for the system or lifestyle. But our specialists may or may not know about it, and we need internists, we need cardiologists, we need every stripe and color of doctors. I can tell you that the biggest part of my job, as Dr. Landman and some of the members of my team who are here today know, is calling doctors in the community, calling friends, calling colleagues when I need a particular type of specialist. In fact, I was thrilled to be here yesterday to hear the doctor who spoke about sleep disorders, because I've been desperately looking, and you'd think in New York with 4 medical centers there'd be experts who have some knowledge of working with people with sleep disorders, and the only thing I can get is a sleep study and CPAP, and that just doesn't work for most of my patients. So I was thrilled, and that's one of the reasons this conference gives us the opportunity to see people who think out of the box, who are doing things that cross disciplines and are able maybe to give you some guidelines. And that's something that you, as if I consider it my job to be on the edge learning. That's the good and bad part of this. You need to devote time outside your own specialty to talk to other people, to find out what the latest cutting edge approach might be, so that perhaps we have a patient in Canada who's severely crippled with Parkinson's. The diagnosis wasn't even made there. His son's full-time job is to take care of his father. And so I considered it my job to learn what I could about the reality and then judge the legitimacy of the research. If I wait 10 years, when it becomes maybe more public knowledge, my patient will be gone. And so that doesn't work. And that's where you begin to put the bits and pieces together. So you weave a fabric of trust with your patients so they know that when they need to turn to somebody, you become a valued member of their team. One of my closest friends in marketing, when he talked to me years ago about my business vision and my medical vision, he said, you know, what you're really saying is you're asking the patients to pay for your brain, but pray for your heart. And so a piece that I heard said very eloquently by Bob Willick and others on the first day of the conference is just that. You need to work with people in a state of compassion. You need to really care. It's difficult to care when you're seeing 25 patients a day and you have 2 seconds to give to each of them. And at the end of the day, you're completely wrung out. So it's a double-edged sword because you then have to be available to keep learning. And that's a critical piece of this, and start discarding what you think may have no validity, but looking deeper at things that do. This is a sample of a family issue. In fact, both of them are my patients. MB is a 21-year-old college senior at this point, but I met her back when she was a sophomore, and I met her because her father asked me as a favor, because of my background, even though I wasn't doing this anymore, to consult about her secondary amenorrhea. Unfortunately for this young girl, she had been a dancer and was striking, but had a very unhappy episode happen. She was raped as a freshman, which I didn't find out until the second time we spoke, and that caused a sort of downhill slide. Ultimately, that improved. She did have anxiety and depression around it. And one other piece from history, because she switched schools to Tulane, is as her physician, I was actually able to get her a single room at Tulane because she needed that because of the anxiety and the depression that emanated. It was very hard for her to have other people close and share rooms. And that was something as a physician that I could easily provide. And it made a huge difference to her father and family. They still thank me for it to this day. It took me 2 seconds and they thank me for it. So he was currently worried about her. He calls the office because apparently there might have been a fungal infection, and this dad is a wonderful dad. He actually got all the girls out of the house and he put them in another house. But even though his daughter had no symptoms, he wanted her worked up. And like the last thing I could be interested in is looking at fungal infections and how you rule them out and how you rule them in. But she was only home for school for 2 days. I had a great couple of ENT doctors, but we had a coordinator appointment, so we got the lab test. Members of my team did the initial look on, what we actually need to test. I ordered the test, and then she was positioned to see her. We coordinated an appointment in the narrow window of time she had with the doctors who are perfectly willing to do that with me now because they see the kinds of patients we treat, and it's easy for them, so they'll squeeze them in. Instead of waiting 4 weeks to get an appointment, she was able to be seen right away, and her testing was negative, and this, of course, reassured the father. They will always stay my patients. In fact, that other father and son, not only have I seen the two of them, but the daughter, now the wife, and the son, I actually helped them find a doctor for his issues. So that goes on and on. That's the growth that you will see. I promise all of you, if you tap into your roots, think about the rigors of your training and what it really meant to offer that compassion and care for that patient and not stop at the boundaries of your own discipline, makes a huge difference. So by projecting into the future of healthcare, we're looking at being medical advisors, financial, just like the financial and legal community have had for years. I pay a ton of money to my lawyers and try to do without them, but that doesn't always work, and the accountants. And yet, when it comes to turn around to what we advise, and we've had such a delayed entry into the work world with debts that run hundreds of thousands of dollars, why not? This makes so much sense. We have no stake if we separate ourselves and truly practice in this fashion. I don't have any stake in prescriptions or surgery. So I want to just decide from that patient's perspective, do they really need that heart surgery, or can we do something else? Coordinated access, limited resources in the future for us aging boomers and our families. Knowledge is key, but that wisdom I spoke about in interpretation is vital. So you can be positioned as a trusted source of wisdom to interpret and guide decisions. So in terms of another trend that I see, which has overlaid this whole vision, is the fact that we are no longer the way we used to see our mentors and teachers when we were in medical school and in early years of our training, run an office, come in and make rounds in the morning, sit and chit-chat, really get an understanding and involved. The hospital, the technology, what's going on there, critical care, demands expertise that I, for one, don't have. So I see a future in medicine that starts with aggressive prevention, not just take an aspirin a day and try to stop smoking and don't eat, high-fat foods or high carbs, but rather being in this position of optimizing and advising. And then in the middle, there's a primary care, and that may cover, over branches that range from gynecologists to generalists to family practitioners, hospitalists that do critical care and everything in between. And so that's where I see, if the healthcare system translates, that we can take this good medicine and transfer it into good business. Because as we grow with our patients, as we refer and advise, we become their trusted advisor. We become the replacement for the doctors they used to turn to, they used to call, they used to send their children to, they used to take care of 3 or 4 generations. And to have that again back in the lives of our patients, and I'm sure many of you, from just hearing you speak up here and interacting with you, have that kind of practice to some degree. But now it's time to leverage it in a way that the new world of medicine is actually, it's not just a choice, it's going to demand us to do that. So how did we get where we are today? A cholesterol of 250 just a couple of decades ago was fine, and you didn't have diabetes unless your sugar was 124. Who knew women had heart disease or that men got osteoporosis? In fact, even today, the Mayo Clinic, many of my patients are regulars there, and I'll show you one of them as we get to the end of this. He just was seen a couple of months ago. He's 69, and he loves his doctor, called me up when he came back from his doctor, said, "My doctor thinks my testosterone's normal." Testosterone, free testosterone was about 30. I said, well, that's fine, okay, and it's the same as it was here, but I don't believe in normals. I gave him the whole idea of what a reference range is and that normals are meaningless. And then I said, so what did your doctor think of your bone density? He said, what? I said, did your doctor ever do a bone density? Do you know that men get osteoporosis in the same number as women do as they age? It just starts a little later. He said, no, never did that. I said, well, we happen to have your results right here. And you're completely osteopenic. And in fact, there are lots of areas in your body you're actually osteoporotic. He's taking care of a young child from a 3rd marriage late in life who's 6 years old. He's the primary caretaker. He said, you mean I can break my hip? Or like my mother? And I said, yeah. So I said, why don't you have a little chat with your doctor, and I'll be happy to give him a call and send these results. And guess what? Guess what's the most important factor in terms of your bones? It's your testosterone level. We don't look at your score compared to other people your age. We look at when it was prime. And when it was prime, your testosterone was probably more like 150. So I'll be having that little discussion with your doctor, and it should be lots of fun. So you don't always get it that perfectly, but it helps, Mayo tends to be very conservative. They're beginning to think about doing bone densities in men. Their approach to it currently is you do a bone density when they fracture a hip or they have a fracture. Why do it before? Okay. So what do most doctors know about exercise or nutrition? I didn't warn my son, who's a 4th-year medical student, here today. I didn't ask his permission to use his name, so I hope he forgives me. But he was, captivated by the day of nutrition and exercise because he hadn't heard a thing about it at Yale Medical School. And that was, wonderful. I mean, here, one of the best schools in the country, or so we think, no time to do exercise or nutrition counseling. It's considered ancillary knowledge that you should figure out a way to pick up on your own. And we don't take trends into consideration. So age management medicine is a definition. It's really about a proactive approach to aggressive preventative medical attention and care. One of the most powerful concepts which we heard by the speaker right before me is that we inherit genetic potential, but not genetic certainty. And 65% of our health issues are environmentally driven. Genetics loads the gun, but environment and our lifestyle pulls the trigger. But it's through changes in lifestyle and diet and hormone modulation that we can have a positive impact on the aging process. I like to use this picture because this is the person who's my trainer and pushes me around. And for the last year or so, he was telling me about the fact that he was passing out various times, and he was peeing a little more often and drinking a little much, figured he got dehydrated. He even showed up in some emergency rooms, and everyone thought he was just fine, because this is his before picture. He's used in the ad campaign at the gym that I was in. And this is what he looked like. So he looked fabulous. There's a big picture of him at Grand Central Station. And of course, without doing much more than saying, okay, let me see what's going on here, We do the questionnaire, we do the blood work. He's spent, by the way, millions of our taxpayer dollars because he's a vet. So he has some pretty good doctors at the VA who have a lot of NYU doctors there. And everybody noticed, occasionally he said to me, I said, did anyone ever ask you about your sugar levels? He said, yeah, they'd mentioned it was slightly high, but he was eating every 3 hours. Once they found that out, they just wrote it off. Well, he was eating every 3 hours as a trainer, but also every single member of his family is a diabetic. So even though he looked great and there was no reason to think about that, no one ever did any tests on him. They worked him up neurologically and they figured he was fine because he looked so good. Well, he wasn't. This is his data, and again, we don't have much time to look at it, but you know, most of my doctor colleagues and all of my endocrinologist friends would laugh, but he's a diabetic because he's doing everything he can, yet his hemoglobin A1C is 5.9. He's hyperlipidemic. He probably has postprandial hyperglycemia. And his numbers did not look really good. His homocysteine was 13.3. Put him on glucophage, which he didn't tolerate well. He did great. He lost 20 pounds. So his numbers were back up again in June. His cholesterol, translated nicely. And his testosterone was 77 on HCG twice a week. At the peak, it was 196. At the nadir, meaning he was due for an injection, at the second injection, it was 111, so it was perfect on HCG. His numbers had all begun correcting. Of course, his estrogen went up because he was making more testosterone. It was aromatizing. No symptoms, though. His DHEA was fine, overdid it a little bit. Cardiac CRP was okay. It's been dropping, and his vitamin D has now gone up to 84. Unfortunately, because of testing that we had, his lipid profile, this is something else we do. We look at a deeper lipid profile. We look at the number of particles. And if you remember, actually going back to the slide before, this was done here when his lipids looked pretty good. His LDL was 100. I think most of us would be happy with that. Just looking, and his total cholesterol was 139. But if you look at his NMR, which looks at a lipoprotein profile, you can see that he had high particles. He had a ton of particles floating around and super high numbers of small ones, even though his total cholesterol was 189. And this was when he would look good on the surface levels. So that obviously we have more work to do with him here. We also did a VO2 test with Stephen Villagomez, as many of you know, our nutrition and exercise physiologist with superb training. He came into me, he said, this does not look good, and this is a guy who's a trainer in great shape. His VO2 and his METs, and then in August, the improvement was pretty dramatic. Unfortunately, it wasn't early enough to prevent what he probably had was a silent MI, or maybe he had some pain and wrote it off, being a tough guy. I didn't show you his CBC, but when we first took the numbers, he had a rip-roaring flu with like a white count of 1,000 and a major shift with lymphocytes, and he was working. But anyway, he had a mild anterior basal prior damage and maybe an inferior wall fixed defect, but that was probably fine. This left ventricular myocardial wall motion demonstrates septal wall hypokinesis and questionable minimal anterior wall. So he had sustained probably an MI, but given how good shape he was in, this is a picture of somebody who, if he did want to run a marathon and all the factors didn't align, he might not have made it. If you look at this other gentleman, came to me from Texas, and if you look at his fasting blood sugar, he had just been seen by a cardiologist who basically said to him, you're okay, you're not too bad, why don't you just try to lose a little weight? Well, these numbers didn't make me happy at all. And look at that cardiac CRP as well as his coronary risk ratio. And so before I even saw him, in Arizona, he had an NMR test, and lipoprotein profile plaque and lipo-a, and you can see how awful it looked here. And then this was him 6 months later, and it was almost all in the optimal range, although his size had gotten a little smaller, and I'm still trying to talk to cardiologists to figure out why. He went to see the cardiologist in New York who did a carotid intima medial thickness. The guy called me, and when my patient walked in, I never met him face-to-face yet, he said to me, well, do I go straight to the OR? But he was able to turn around disease, and he's in phenomenal shape now because of the treatment. Now, I want to talk just briefly and show you a slide. I use and I refer people to other kinds of conventional medicine. I believe, and I've studied as an open-minded skeptic, lots of areas of complementary and alternative medicine. I served at the Institute of Medicine Committee with David Eisenberg and some of the other leaders in the country, mainly because of my research background and interest in an integrative model of health care that I had created. So traditional Chinese medicine, and one of my favorite ways to manage patients' stress level, is by using Qigong. And the gentleman back there that worked so hard to get this going.
In Australia, I met a Chinese healer who worked with energy, something called Qigong. That in itself was an enlightening experience. Using his fingertips only, he would channel energy through his fingers straight into my body. I'd never seen anything like that before. And obviously never felt anything like it. The first time I felt the energy shooting into my body, I thought he had like an electrode on him somewhere, hidden under his shirt. I just couldn't believe that there was somebody alive who could do this. And yet, he could. And he did. And my muscles shot up in response. It was utterly amazing.
And this kind of setting can go so deep, it can refresh the body. It can go into the bone marrow, and it can go spiritually and emotionally.
Like a spider wave went through the forehead. Electricity, amazing.
So the people, they have this kind of setting very instantly feel charged or, energized.
I had a pain in my lower left quadrant before I went to see him that was really starting to concern me. And he shot energy into that area, and within a day and a half, the pain was gone and hasn't returned in that area. So, I'm a believer. I have to be. I've experienced it.
Thank you. So the details, Blake is the wife of a very prominent plastic surgeon, and when I came to New York and he became my patient, I told him my interest in networking with all kinds of physicians. So Blake had been diagnosed with a very malignant ovarian cancer. The pain she was referring to was after a very, rigorous course of treatment at Sloan Memorial, against the advice of her doctors, who said the lesion looked cystic, so it was probably no big deal, let's follow it. She was only 37 at the time. And they treated it in the usual way, and she went off because she's a producer and was doing a documentary in Australia, where she met up with Robert, who had been brought there by the Prime Minister to heal his daughter, who had chronic fatigue syndrome. And she basically went up, she's a pretty brave woman, and she felt this lump growing again in that area, and she went up, knocked on the door of the Prime Minister's home, demanded to be seen, she had read a little blurb about Robert after missing her plane. These things are meant to be in life. And she demanded being seen by him. And what she told me since, because we've become friends, and I know Robert well, and I use his Qigong methods with my patients, is that basically it was like doing surgery without anesthesia. And if you've ever had him touch you, the tingling and the sensation feels like he's plugged into something. He's amazing, and you will probably end up seeing him on Oprah. I've brought him to Yale to lecture, both at conferences and to students, and they were blown away by him. My sons, I might add, when I told them I was just coming back from seeing a Qigong expert, told me that they warned me never to mention that when I was at Yale hanging out, that it wouldn't be a good idea. So now they've met him, and they've actually had the experience, and they know what he does. So if you can look at this gentleman, I like to use Qigong. You can see his cortisol, which was 19 at baseline, super stressed, running an organization. He actually had an MI several years ago. This guy looked good enough pre-treatment. He had a little pot belly that you thought he was in great shape, but he was very stressed. He had a stent placed. And his cortisol was 19, and non-invasive ways of doing it, he was starting to do the Qigong on his own, and it dropped dramatically, and he stopped doing it, got busy, it went up. So he's done very, very well, also on HCG. I'd like to point out with him, too, just to have a touch of hormones here, that when I see an LH of greater than 5, I can't rule out whether it's the patient is still in the hypogonadotropic hypogonadism state, meaning periandropausal, where their body is still able to respond to HCG, which I like to use because it's more physiologic than shutting down your testes with testosterone, or it's a pulse, because remember, all these things pulse. In his case, given the exam, the physical exam, and other reasons, I usually like a trial of HCG even for 2 months. He responded robustly, and he's actually on a fairly low dose of HCG, and he remains on it. You can see what happened with his estradiol. And another point I want to make is that in the first 6 months to 9 months of treatment, it's not unusual to find an estradiol and a DHT that can go up. In fact, given my background in pediatric endocrine, 70% of all boys have gynecomastia, either unilateral or bilateral, and it's not uncommon to see that in our patients as they begin to evolve, because remember, they've downregulated and then they're going to upregulate as they go forward, and their systems are still unstable until they sort of get the training wheels off. Also, you can see what I also commonly see. He was extremely growth hormone deficient with an IGF-1 of less than 100, had all the symptoms. Without any intervention, his growth hormone went to 141. It doubled. I see this all the time. Not everyone makes it all the way, but I usually give them an opportunity of months to sometimes a year. His lean muscle mass and change in terms of grams went up in a very short period of time, because he was one of these who went out and just did it. And his percent body fat dropped dramatically as well, losing over 6% at his trunk alone. We know what this is about. We know the fact that, we don't know if it'll lengthen our lives, but if you just take Tim Russert as a great example, he didn't need to die at 58. And it's likely that we all looked at him on Sundays and we said, he's a walking heart attack. I hope someone's doing something about it, but likely not. So longevity, obviously, if you don't die at 58, you're going to live longer. So think of our patients not as sick, but as clients. They're not necessarily healthy, even though they're not sick. Disease just hasn't emerged yet. Symptoms may be present, but unrecognized and undiagnosed and compensated, explained by aging, stress, denial, all the usual reasons we all use too. This is an opportunity for us as age management medicine doctors to extend beyond hormonal optimization and lifestyle, assess all abnormalities, and address critical findings as soon as possible. I'm going to skip this because I don't think we have as much time as I had hoped, and it just talks about the process itself.
Dr. Comite, we don't have any time.
Okay, so I think I'll end. I just want to end with a thank you. Let me just, can you get to the end of the talk? There's a, and I can go backwards. I just want to make sure to thank my team for, without them, I honestly wouldn't be able to do this today. They've learned and grown in so many ways, and 2 of them are off at medical school. Another couple are planning to do that. I have a strong belief in training the next generation of doctors in this new, brave new world. Can we get on to the end of it? Oh, I'm sorry. Could you go back? These were slides I eliminated, or I could go back. Go to like 95 or something. No, okay. Let me go forward then myself, or can you go forward? Yeah, let's go to the one right before the Dr. Seuss. You're only old once. Okay. So I just can you project that with the title? Okay. Well, in any case, I show that as the past, present, and future team. Creating the team gives me a lot of pleasure. It's also a lot of work, but it's a lot of fun because our patients come in and there's an atmosphere of hope and compassion and interaction with all of them. Thank you very much.